It's my pleasure to welcome you back to the AHSN Network Innovation Zone Theatre. Thank you for joining us. I'm very pleased to say that our speakers for the next session are here. So it's all about scaling innovations for children and young adults. I hope you'll enjoy it. Do please listen hard, get ready to ask some questions later on. I'm sure there'll be a chance to do that, won't there? Brilliant. So I'll hand you over for the start of the session. Thanks.
Thanks very much, Dave, and a warm welcome, everyone. Thank you so much for joining us this afternoon. It's a wonderful programme, so we do really appreciate the fact that you've come and chosen to see us today. My name's Laura Semple. I'm the Director for National Programmes within the AHSN Network Central team, and we'll say a bit more about AHSNs in general in a moment for people who don't already know us. And I'll just ask Mark to introduce himself briefly.
Thank you, Laura. So I'm Mark Dines-Allen. I split my time between East Midlands AHSN, and that's why I'm here today to talk to you about one of the national programmes, and Yorkshire and Humber AHSN.
Thanks, Mark. Just want to double check, we're kind of Newsnight style here today, aren't we? Can everyone hear us okay? Fine. We had a few audio issues this morning, so just wanted to check that. Marvellous. As Dave said, we're here to talk about scaling innovations for children and young adults. It's a subject very close to my heart, and I'm thinking yours as well, which is why you're here. Without any further ado, we will get cracking. So, for anyone who doesn't know about academic health science networks, we're a connected network of 15 networks, and you can see all 15 there on the map. And our job is to speed up getting innovation into practice on the ground in the NHS. So every network you see there on the screen works very closely with the hospitals, GPs, ICSs, universities, innovators, industry partners in their patch to really speed up getting the best possible things to patients. And we're going to talk about two particular examples of those today. So this is our ambition, quite simply, to improve lives through health and care innovation. And we do that in a number of ways. And also through our work with innovators, we are also able to create jobs and do various other activities which drive economic growth in each of our areas. And for me, a very important principle is that whenever we make things better for people and patients, generally, we save money at the same time. That it's important to me that we do it in that order. But in my experience of any kind of improvement project, when you actually get it right first time for the patient, very often you save money along the way without that being your first intention. And I think we've got a few examples of that. The beauty of the 15 networks is that we're able to work together as a network of 15, I think, very well. And that's my role, or part of my role in the central team, to really help the networks to work together as productively as possible. And one of the main ways we do this is we have a series of national programmes, two of which you're going to hear about today, where all 15 networks have committed to working on something in a consistent way together, because it has a really strong evidence base and actually the need is very consistent across the country. AHSNs also have the ability to do local programmes which respond very much to local needs in their local regions, so we do both. We have the high evidence, broad reach programmes that we do nationally, and we have our local responsive work as well. What we're able to also do is do this import and export of innovations between regions, which without AHSNs would certainly not happen in the efficient way that we've managed to design through our innovation pipeline. So, as we said in the intro, the focus today is on two innovations for young children and young people. And the first one is Focus ADHD, which Mark is responsible for leading across England. And I'll hand over to you, Mark.
Thank you, Laura. So Focus ADHD is actually a really good example of the work the AHSNs can do. The programme started at Confed a number of years ago with a conversation between an innovator, a smaller company, a clinician, and a member of the network. First slide, please, Laura. Thank you. So, what is Focus ADHD? So, it's a program where we're putting in an objective assessment into the diagnostic pathway for children between 6 and 18 that are being diagnosed for ADHD. So it's a tool to help rule in or rule out. The traditional process of diagnosing ADHD is very subjective. It's reliant on views from parents, schools, clinicians, etc., to make that diagnosis. And this gives an objective assessment to help with that subjective diagnosis. So it does not replace the clinician's judgment at all. So the test itself measures the 3 core components of ADHD: attention, activity, impulsivity. Now, when we look at an innovation, we want to know about the case for change. Why do we need to look at innovation? For this program, 1 in 20 school-aged children worldwide have ADHD. ADHD assessment pathways differ in England quite dramatically. Some areas it's CAM services, some it's paediatric services, some areas it's both. But the pathway can really differ. Assessment processes are mainly subjective historically, and on average, this is pre-COVID, children were waiting 2 years to get their first appointment and then another 18 months to get their diagnosis. So once we look at the case for change, we look at the evidence base. So what is there that says this tool, this innovation can work? So there was some number of publications and an RCT. So this was done in a traditional manner for an RCT, but we wanted to look at that evidence base, which showed it could save savings in terms of the amount of appointments needed, but look at it in the real world. So East Midlands AHSN conducted a 12-month evaluation with 3 trusts in the East Midlands across 7 sites. And in that time, we saw over 1,200 children go through their normal pathway with the addition of having a QB test, this objective assessment. So our findings were reduced by 5 months, 153 days, the times taken to get a rule in or rule out decision. The number of appointments required was reduced at 2 of the trusts by 1. So we were saving an appointment for every child referred. Just out of interest, the other trust used it for complex-only patients late in the pathway, so there wasn't an opportunity to make the same savings. It released clinicians' time. There was great buy-in from parents. Clinicians loved it. And also, we delivered a saving. And as Laura said, that wasn't the primary objective for this program. It was about quality improvement, but we delivered a saving for the system. So, the impact since we started our real-world demonstrator. So back in 2017, only 22 trusts were using QB test. We're now in 60 trusts across 117 sites. We're at 55% of trusts. We've got a way to go, but we're in our 3rd year, and we're really confident of increasing those numbers. Using our real-world evaluation evidence, that's 62,000 appointments saved, which equates to £10 million in cost efficiencies. Now, that's capacity released back into the system. Within the real-world demonstrator, we won a HSJ award, and I'm really proud to say in March this year, we won a partnership HSJ award within mental health. And one of the judges quoted when they gave us the award that they saw this as a game changer for ADHD diagnosis for children. I'll now hand back to Laura.
Thanks, Mark. So there you've heard about our results and impact to date with Focus ADHD. I'm now going to talk to you about the second programme, and then at the end we'll talk about some of the learning that we've had actually across both programmes that we'd like to take forward in our future work. So I'm now going to talk about something different, which is our programme on first episode, Rapid Early Intervention for Eating Disorders for Young People. And the acronym for that is FREED. And this is a programme working with people between the ages of 16 and 25 who have eating disorders with a duration of 3 years or less when they're referred to the teams. Before I get into the detail of this, I do want to say you can see in your programme somebody called Amy Semple, who's actually no relation to me, but we do work closely together. Amy Semple is the national programme lead for this, and she did want to be here today. Unfortunately, something's got in the way. So I'm going to be talking to her slides, and I do want to fully credit Amy as well as Aileen Jackson at HIN, as well as the team at the Maudsley NHS Mental Health Trust, which is Ulrika Schmidt and Danny Glennon, who are really the core team that have really paved the way and pioneered FREED. So, what is it? FREED is a service within a service, And the aim is to shorten the duration of untreated illness, prevent functional decline, and increase probability of recovery in young people. As I said, the original innovation was designed by, and I think this is really interesting actually, Mark talked about the QB test, which is obviously a commercial innovation. Freed is very much an NHS innovation. This was born from the Maudsley NHS Trust, designed there and worked very effectively in the original research there. So then it was decided to scale it up to 4 mental health trusts, and because the evidence of that was so strong, we actually selected it to be an AHSN national programme. The service within a service really focuses on having a really positive, young people friendly approach. There's a real focus on the fact that, you know, this is quite a sensitive time of life. People are maybe starting university, starting work, and it's around, you know, really focusing on the things that are important in people's lives and supporting them to make the changes that will help them to get the most out of what they're doing. And as I said, the style is very person-centred, youth-friendly and motivational. There's very active engagement with exploring issues like things like social media use, which we know are really important. And I've included some statistics there on the right-hand side. I'm sure everyone here is aware of the seriousness of eating disorders. They're the mental health condition with the highest mortality rate, and we have seen a huge increase in referrals to eating disorder services during the pandemic. So we're proud of the contribution we're making through this programme, but we do recognise that there's so much more that needs to be done, and we'd like to be part of that in the future. So I just want to talk you through some of the data that we have on Freed. It's a really, really strong evidence base from the original site and the first 4 sites that Freed actually spread to. So you can see really meaningful outcomes here, like reduced need for intensive treatment. That's reduced need for day hospital and inpatient care. We're also able to see people actually recovering quite well in many cases, and their duration of untreated illness is generally shorter. We see this as, you know, something that's proving really popular with patients and their families, and families are often actively involved in the care. Obviously we can see some cost savings, most of which do come from the reduced need for day hospital and inpatient care. And the really positive thing as well is we've actually just published a paper just last week, so unfortunately it was slightly too late to include in these slides, but we're collecting these outcome data across all of the sites. It's now 40 plus sites across the country that have adopted Freed. And although it's still slightly early days in some cases, we are seeing that it's scaling very well. So many of those original outcomes we are seeing being sustained across the sites, which is obviously exactly what we intended. So that's really rewarding to see that happen. So how far have we got? You can see here that we obviously have 57 eligible mental health trusts, and you know, we've got 40 having adopted Freed with 15 partially adopted. When we talk about partially adopted, in some cases where services are really under strain and having you know, a huge volume of referrals, they're not able to offer the new service immediately to all patients, so they've had to limit it in some way. But obviously we're supporting them all the time to try and broaden that access out and make it fully available. So we're really optimistic actually that by the end of this financial year we should have very close to full national coverage, if not 100% national coverage of this service. And it's been great to hear from the Freed teams on the ground that they're saying that some of the actual principles in Freed they're actually applying to their whole eating disorder service because they're finding it so successful. So that was a brief canter through some of the impacts. I'm very happy to take questions on that once we've finished, but I did promise we would share some of the learning that we've got along the way on these programmes, and I think it's fair to say some lessons feel common to both programmes. In some areas we've learnt some slightly different things, so I'm going to hand over to Mark to take us through some of that.
So the first thing I'm going to look at, and this is the role I've been doing as a national programme manager for the AHSN, so I've been liaising with all 15 AHSNs and their local programme managers. So the first thing we need to do is upskill the AHSNs so they can then support their systems, their providers and their commissioners with their local programs. So the first thing we do is we get a toolkit ready. So guides, FAQs, the evidence base, etc. We try to build the capacity and capabilities, but most importantly, we've got to start working with the stakeholders and understand where the opportunities are. Look at the data, look at the services that we need to liaise with whichever program it's with, so that we can work with them to grow a service within their locality. We really support communities of practice, so we get key stakeholders across a locality together. Now often we find these stakeholders may not have met previously, so actually it really prompts a learning culture between them. The shared learning opportunity, I think, for the AHSNs is really important. So the learning we get from each of our national programs, they really do go across many different aspects of change and project management within healthcare, so we can share that with our stakeholders. Most importantly, I mentioned with Focus ADHD, we started by looking at the evidence base. We then need to look at the evidence base of the success of our programs. Are we realizing the benefits that we set out to do? So the Focus ADHD program is now going through a national evaluation, and hopefully we'll be publishing that in September time, so we can show the impact we've had. In terms of the enablers and barriers, so both programs launched in April 2020, the first lockdown. So for Focus ADHD, huge barrier, there were no face-to-face appointments, and this is a face-to-face intervention. So that was an initial barrier. However, as trusts started to put their recovery plans in place, it became an enabler because we were releasing capacity. So whilst it held us back initially, it then became an enabler to help us drive the program forward. Clinical reticence. So some clinicians, they think that they don't need this extra piece of technology because they've been doing this for 10, 20, 30 years. However, the way we counter that is by having dedicated clinicians that are expert in this field, have used the technology to have those clinician-to-clinician conversations. Also, we look at things like the additional costs, and we support the sites with business plans, etc. So wherever we find a barrier, we try to find an enabler to compensate for that so that we can then support driving the program forwards. But really, for me, one of the most important things is the stakeholder relationship, including patients and carers. So our steering group, we have NHS England, we have paediatric and CAMS consultants, we have the ADHD Foundation, and we have parents sitting on that steering group, so make sure the patient voice is at the centre of our program. I'll hand back to Laura for the freed learning.
Thanks, Mark. So I think these are some quite helpful categories of learning that could be quite usefully applied to lots of things. And when we think about the pandemic context and the workforce and funding challenges, I think this played out slightly differently in the case of our eating disorder programme. You can see here we've listed as enablers the national drivers. So the really critical thing I do want to emphasise is we've had a really strong partnership with the NHS England Community Mental Health team, and through them actually accessed significant funding that's gone out to trusts to support them to implement the freed model, which has been a real advantage. However, that hasn't been a whole solution in itself, because we have found in some cases, for example, trusts may have the funds to recruit the additional staff that they need to start freed, but they're just unable to recruit. So there's a real workforce shortage in the professions we're looking at for freed. So as I'm sure you're all more than aware, money isn't the whole solution, and so we've had to think quite creatively on the workforce front, and some trusts have had to adapt the type of roles they're recruiting to and look quite creatively at each of their posts. The other things that I think probably do have quite a lot in common with what Mark was describing in the experience with Focus ADHD was freed does require teams to do some additional and new things. So, for example, we're only able to present that outcomes data that I just showed, which is so important, if the teams track the outcomes at patient level and share that with us routinely. Now, that's quite a bit of additional work, so we've had to support people quite a lot with that, and really conscious of the workload that everyone's grappling with at the moment. In terms of clinical leadership, the team at the Maudsley in South London have been absolutely brilliant and have provided really first-class clinical leadership to this. And I think they've led the development of a really positive and friendly, freed network that all of the sites feel part of. So they not only have the opportunity to have direct clinical supervision with the Maudsley team, which is really confidence building and important just while they're getting the service up and running. They're also part of a really supportive wider community, and I think that has really helped people meet the quite significant challenges that they've faced in many cases. And I think we'll pop to the next slide. So, this is our last slide, just a summary of some of our learning. So to start off, the innovator relationship. So I think we've learned a lot through both programmes about the relationship between the lead AHSN and the wider AHSNs and the innovator, which is Cubitest in Mark's case, and the Maudsley team in the case of Freed. And that relationship is really core to everything. And so we've spent a lot of time in getting that relationship as best as it possibly can be, and paying a lot of attention to the fidelity, so what is core to the innovation that cannot be adapted, and actually what is amenable to local adaptation, and getting that balance right is just so important. The second point around the mapping, so I think, to be honest, this has been more of a challenge for you, Mark, hasn't it, where, as you mentioned, pathways to diagnosis of ADHD are very, very complicated, and we've got a huge number of providers involved. So actually any AHSN trying to support their local teams to implement Cubitest needs to spend quite a lot of time understanding what's going on in local pathways before they can make a start. That is time that is so well invested. You can't do a good job of this without doing that. And also, obviously, without that baseline stakeholder mapping, you can't begin to understand what impacts you've had. And I think Mark and the team have done a brilliant job, and you saw that excellent inflection chart of capturing the impact through the programme. So system levers, I think, for our eating disorders programme, we've had some really strong national drivers and national levers. We've had all the commitments in the long-term plan and the community mental health transformation plans, which has been a real strength for us. And, you know, I'll say it again, we're incredibly appreciative of the support of the NHS England team, without which we wouldn't have been able to do this. I think in the case of ADHD, there's been quite a lot of publicity, hasn't there, about the length of waiting lists for diagnosis, which are just far too long. And Cubitest is one thing, among others, that can really help with that. So again, that's been a good lever in some cases. The points here about scope, I think I've really already mentioned, around striking that really fine balance between having enough fidelity so that you don't water down the innovation so that it just really doesn't work as well, but also having enough flexibility to local context, which is important. And I think AHSN staff are becoming quite expert in how to walk that tightrope. So if anyone's kind of needs advice on a subject like that, I'm sure your local AHSN team will be happy to help. Looking to the future, you know, we really want to see both of these sustained really strongly in the system from the next financial year, which is when the AHSN teams will actually need to start focusing on other work. But I think we're starting to plan that quite well, Mark, aren't we? And looking at a range of sort of contractual levers which will help the sustainability, but also various ways in which we can keep up the energy in the national community of people who've really driven this and implemented it on the ground. AHSNs only deliver through our partners. Without our partners out in the systems, we wouldn't have been able to do any of this. And clearly we're really keen that they sustain the sense of ownership they have of these things and allow them to continue to flourish and develop well beyond next year. I think the final point we just wanted to share with you is the message of just get started. So I think that's something we've learnt through both of these programmes, is that for very understandable reasons, teams often want to feel like every T is crossed and every I is dotted before they start. And obviously if there's a certain amount of preparation that's essential, otherwise, you know, things don't work well. But we have also worked with some teams who've been so diligent about that. It's taken them months and months to start something that actually, frankly, if they just got on with it a bit earlier and been sort of prepared to learn along the way, we might have got more value collectively. So that's one of my top tips is, just get started in a safe way, of course, and AHSNs are there and with teams all along the way to help where that's needed. So I think that's really it from us. But I think, Joe, we've got a few minutes of questions. So, invite any questions. And if you think of anything afterwards that I've not had a chance to answer today, I've included our email contacts there and would be only too pleased to hear from you. So, over to you.